So let's start with an introduction, which is my synopsis of what I believe it's current and new in the field of pediatric neuro-ophthalmology in 2022.
Hello, welcome everybody to this first talk of our pediatric neuro-ophthalmology webinar. I titled this talk, What is New and Important in the Field of Pediatric Neuro-Ophthalmology. I hope I have chosen the 5 articles which will help also others. So these are articles published in the well-established journals with I haven't chosen them by accident. I was consulting my co-workers, people with whom I take care of pediatric neuro-ophthalmological patients. The title of the first paper I have chosen is the Pediatric Optic Neuritis Prospective Outcomes Study. So 2 years results. This was a PEDIC investigation group and was published in Ophthalmology in August this year. This paper was a non-randomized observational study at 23 pediatric ophthalmology or neuro-ophthalmology clinics throughout US and Canada. The purpose was 2 years follow-up. Their outcome were visual acuity, recurrence risk, and final diagnosis. At enrollment, 44 children were included, but only 28 completed the 2-year visit. 10 years was mean age at the first enrollment of the study. About half of the included children were girls, about half boys. More than 65% had unilateral optic neuritis, the rest had bilateral optic neuritis at presentation. Visual acuity. As we all know, visual acuity improves quite fast in pediatric population after optic neuritis. Also in this cohort, mean visual acuity was 0.16 at presentation. After 6 months, mean visual acuity was already 0.8 and remained within these boundaries. After 2 years, 6 children didn't achieve normal visual acuity for age. 2 were diagnosed with NMOSD and 2 had multiple sclerosis. The rest, 2 of them, had isolated optic neuritis. 18% of participants had relapse, some kind of recurrence, 3 relapses, and 2 new episodes in previously unaffected eye were marked. Final diagnosis after 2 years was in a great majority, so 39% for isolated optic neuritis, 29% for MOGAD, so myelin oligodendrocyte glycoprotein associated demyelination. Then following with multiple sclerosis, 7% had ADEM, so acute disseminated encephalomyelitis, and the rest had some kind of neuromyelitis optica spectrum disease. Second paper was about OCT, the role of OCT in managing intracranial synostosis children. This was a paper published in Child's Nervous System in 2022 by a Dutch group of investigators. The purpose of this study was to obtain pediatric normative reference values, as we all cherish very much, because in different OCT machines we don't usually get normative data for particular age. And then they were interested also whether OCT can give an extra value, diagnostic or prognostic value in increased intracranial pressure, whether it is additional value to fundoscopy or not. And the cohort was quite uniform because it consisted only of single suture craniosynostosis patients. These were 93 children, and they also had 64 controls. They were all between 3 and 10 years old. They did fundoscopy, of course, and from OCT parameters, they were interested in peripapillary total retinal thickness and peripapillary total retinal volume. Intracranial hypertension parameters, so-called, were skull growth arrest, fingerprinting on skull X-ray, and headaches. These are fingerprinting pictures from X-ray pictures from this paper. For those who are not familiar what fingerprinting sign is, the number C or the C picture has marked fingerprinting scene, whereas B is only slide and A no fingerprinting. OCT parameters, first fundus appearance. 4% of these cohort patients showed papilledema on fundoscopy. Then they got their normative values for total retinal thickness, peripapillary, and total retinal volume, peripapillary. And they compared their cohorts of craniosynostosis children with these normative values. And 17% of their affected children, of craniosynostosis children, showed increased total retinal thickness, and 16% of them increased total retinal volume. As far as bottom line take-home message of this paper is concerned, they suggest that each craniosynostosis child should be managed with fundoscopy, or each visit should include fundoscopy, OCT, so peripapillary parameters, and skull growth measures. The third paper that I have chosen is the paper about visual snow syndrome. This paper started with a case report of a 13-year-old girl who reported visual snow such as TV static, which was also associated with after images, persistent floaters, photopsia, nyctalopia, and photophobia. Visual disturbances started in the days following the patient's first migraine with visual aura and persisted for 2 years before being diagnosed. So the authors of this paper went thoroughly into this syndrome and made a nice literature overview about it. Visual snow syndrome was, the diagnosis can be made with the presence of visual snow, which lasts for more than 3 months, and some of the additional problems, such as palinopsia, which are after images, and trailing of moving objects, enhanced entopic phenomena such as increased floaters, blue field entopic phenomena, spontaneous photophobia, or self-light of the eye, then nyctalopia or photophobia. The diagnosis of VSS is made clinically with patient's description of visual problems, normal ophthalmological exams, and neuroimaging. Literature overview is quite extensive, or thorough, I must say, because it's not much written about these problems. It was first described back in 1995, and then a paper by Puleda included most patients are included in this Puleda paper from 2020. 40% of VSS patients started with their pathology already in childhood. 70% of VSS patients had a positive history of migraine, 40% of migraine with aura, and even 75% experienced tinnitus. Also, in the last classification of headache from 2018, VSS is recognized as an entity distinct from persistent aura and is instead listed as a complication of migraine. It has been postulated that underlying mechanism of visual snow, similar to migraine with aura, is hyperexcitability of visual cortex, which was also proven later with objective methods such as VEP or PET scan, which has shown hypermetabolism in lingual gyrus, which is involved in post-visual processing in these patients. So the paper suggests that we underdiagnosed this problem. Fourth paper was chosen from the huge field of neurofibromatosis problems. And this paper is dealing with novel molecular targeted therapies for patients with plexiform neurofibromas. I'm sure we all have those patients because neurofibromatosis is quite oftenly seen pathology in neuro-ophthalmic pediatric practice. 20 to 50% of neurofibromatosis type 1 patients develop plexiform neurofibromas, which can cause complications such as malignant transformation, for example, and also pain, low vision if it's orbital and things like that. Treatment of plexiform neurofibroma is often complex, since complete surgical removal is usually not possible due to invasion of surrounding tissues. The present paper deals with MEK inhibitors and other molecular targeted therapies such as cabozantinib, which have proven its valuability in treatment of these patients. Selumetinib, which is an oral MEK inhibitor, was already FDA approved in May 2020. And this product was successful in treatment of more than 65% of children with plexiform neurofibromas. There are also, in this paper, there are also listed all the treatment trials that are currently going on, and including adults or even children with plexiform neurofibromas. And they are really showing great success in treatment of those lesions. For example, they reduce volume of these tumors for 40 to almost 75%. They're associated with decreased pain, and which is also very good. The effect is long lasting, as the studies show. So if we not already, we should, according to this paper, start to use these treatment modalities. Last paper that I have chosen is from the field of neurodevelopmental outcomes of preterm children with or without ROP, but especially the ones that were treated with anti-VEGF drugs. In 2022, at least 3 papers were published. They all included large cohorts of infants of preterm infants And I have chosen the Korean one because it has a very well structured investigation or very nicely understood flowchart. They were interested in neurodevelopmental outcomes after whether the infants were treated or not for ROP. They used a Bailey 2 and Bailey 3 scale. Bailey 2 can give us mental development and psychomotor development indexes, whereas Bailey 3 tests cognitive, language, and motor skills. And they applied these two scales at the age of 18 to 24 months. They were interested first if there is any neurodevelopmental difference in children with and without ROP, and then in subgroups of ROP treatments. So the ones that were treated with anti-VEGF, with laser, or combined. Cognitive, language, and motor delays were significantly more frequent in infants with ROP compared to infants without ROP, which is expected somehow. But no significant difference was observed between the neurodevelopmental outcomes and the treatment modalities. So, to have better knowledge, higher quality evidence, we need randomized trials. These were all cohort studies. So in the future, I expect we will get more information with randomized trials. Thank you for your attention.
Okay, let's go on. My next co-speaker is Dr. Christina Gerth-Kahlert. She comes from Zürich, Switzerland, and the title of her talk is Congenital Optic Disease Appearance to Worry About.
Dear Manca, thank you for your invitation. Dear all who are interested in pediatric ophthalmology. So, next slide. So you all know about the congenital optic disc anomalies, and I've just shown you a few examples here in this slide. So you all know about the optic disc anomalies, and I've shown you a few examples here. So the most important thing after you have diagnosed an optic disc anomaly, you should decide, does the child needs further checkup? Next, please. And so just to kind of warm up, I brought you 3 different questions first. So that's a topless disc, and you see in the lower area of the optic nerve head, you see some retinal nerve fiber layers. In the upper part, you don't see it. So that's a topless disc. So does the child's mother has a diabetic, or does she have a glomerulonephritis? So you will get an answer through the talk. Next. Second question would be, here you see image of the morning glory disc anomaly. How often do you see Moya-Moya syndrome in a pediatric Moya-Moya cohort? Is it 10, 30, or less than 5%? Next. And the last question would be, here you see quite different optic nerve rats. So what would the MRI show? Would it be normal? Would it be a craniopharyngioma? Or would it be an optic nerve glioma, chiasma glioma, and in a child with neurofibromatosis type 1? Next. So we start with optic nerve hypoplasia. So here you all see the fundus, you barely see some retinal nerve fiber layers, but you see a disc. Next. But the disc is not really a disc, you just see pigment, and the circle around shows you the real disc. Next. So what symptoms do we have, or can we see in a child? It's very variable. The child can have nystagmus or no nystagmus. Vision can be 20/20 to no light perception, and associated you can have visual field constrictions. and it can be unilateral, bilateral. Next, and the signs are variable too. The optic disc appears grayish, pale, and you have a double ring sign next. And this double ring sign is simulating a normal disc size. So the ring here, the red in red, shows a normal scleral laminar crepuscular junction. Next. But then you have an abnormal extension of the retina in the RPE over the outer portion of the laminar crepuscular, and that is imitating a double ring. It can be easy to see if the child is quiet, no nystagmus, and you have a quiet surrounding. It can be very challenging in a child which is unhappy to get an examination done. In addition to the optic nerve red I just described, you have a peripapillary pigmentation and you have abnormal vessels. So the major retinal veins are tortuous and you can have an abnormal branching. Next. So what do we need to be concerned once you see optic nerve hypoplasia? It can be associated with maternal diabetic or fetal alcohol syndrome, but we are more concerned about central or nervous system abnormalities, and we know de Morsier syndrome. It was named by de Morsier in the 50s in the last century, and it's describing receptor-optic dysplasia. It includes a small anterior visual pathway, including optic nerve hypoplasia, absent, or it can also be intact, the septum pellucidum. You can have a thin or absent corpus callosum, and you have pituitary abnormalities, and Bill Hoyt named it pituitary dwarfism. You can also have cerebral hemispheric abnormalities. And I would like to point out the pituitary abnormalities. Next. And you can have a deficiency of several hormones. The growth hormones are most common, but in those children, they may have a higher BMI, and BMI, so they can, or the deficiency in growth hormone is not that visible because they have a lot of weight. Children can have a deficiency of the thyroid or cortical hormone too. And it's important if, say, as a child or the parents and the physicians don't know about the pituitary abnormalities, and they get fiber, and they can get in a very stressed situation because they don't have the corticotropic hormone. And years ago or decades ago, when it was not known about the association of optic nerve hypoplasia and pituitary abnormalities, we had several sudden deaths, and papers published about it. Next. So there's a nice paper published in 2006, and they describe that the endocrinopathies are in 72% of those patients, and they're very often subclinical. Next. And very important too is unilateral optic nerve hypoplasia does not preclude coexistent intracranial malformations. So even if you have a unilateral optic nerve hypoplasia, you should get a scan, or at least you should refer to a neuropediatrician and a pediatric endocrinologist. Next. So optic nerve hypoplasia can also be associated with macular hypoplasia, as shown here. The blue circle shows the area where you should have a macula. Those were siblings and they were bilateral affected. Next. So optic nerve hypoplasia can be segmental, so that's child was seen by Professor Landau decades ago. And again, this image I've shown you in the beginning when I had asked you, what is it associated with? Next. And the Professor Landau looked at a cohort of mothers who were diabetic and examined their offsprings. And the segmental hypoplasia, the optic, is associated with lower field defects, as shown here in the kinetic perimetry. Next. And it's also called a topless disc syndrome. It can be uni or bilateral. They have a quite good central vision. The pathophysiology is unclear, and they do not have intracranial abnormalities. Next. Morning glory disc anomaly. I always say it's a very pretty appearance, but it can be a very severe anomaly. It's classified as an excavated optic disc anomaly, mostly unilateral, but there are all reports about bilateral cases. More females than males appear to be affected. So this is a child, she presented at the age of 2 with strabism, and her vision was at the last follow-up at 2100. Next. So visual acuity depends on macular development and compliance, or I would say adherence to amblyopia treatment, because it requires a very strict amblyopia treatment. Next. And the child I show you now, she gained 20/20 vision at distance, has near amblyopia, but just a slight one. Next. But she also has a nice integrity of her macular lamination and structure, so she was able to gain such nice good vision. Next. So what can morning glory disc anomalies associated with? It can be associated with the transsphenoidal encephalocele, and most importantly, it can be associated with Moya-Moya disease or syndrome. What's the difference between disease and syndrome? Moya-Moya disease is just isolated. Syndrome is associated. So once you have an association between morning glory disc anomaly and Moya-Moya, then it's a syndrome. So in the recent years, more and more there's a discussion about when to perform an MRI. Of course, when children are symptomatic, headaches, some ischemic attacks, or should we do an MRI even if the disc anomaly is diagnosed and the child is otherwise fine? Next. So Moya-Moya is diagnosed by radiology, and there just last year there are new diagnostic criteria published and listed, and it's required to have either a cerebral angiography or MRI. And next. So at the Moya-Moya Center at the University Children's Hospital in our city, they looked at the children. There were 100 between 2011 to 2019, and among those 100 children, 51 were isolated, so Moya-Moya disease, and 49 had a syndrome. 15 had neophragbatosis type 1. 1 had a morning glory disc anomaly, and she was symptomatic. Now, in the meantime, they already analyzed 150 children, and now they have 2 children, so about 2%, 2 to 3% of the children are affected with a morning glory disc anomaly amongst the cohort with the Moya-Moya. The indication for surgery is once the child is symptomatic and they have to wait 6 to 12 weeks after stroke. And in general, we recommend once they are diagnosed with a Moya-Moya disc anomaly, we refer them to the Paediatric neurology, and they, Dr. Hagenberg, they work together with the Moya-Moya Center. And they discuss it with the parents, because usually you need MRI under anesthesia. Once the moya is diagnosed, you have a follow-up, so scheduled follow-ups, and it could be done either by MRI or sonographic. If there's no moya, then the question is out for debate, should you do a recurrent MRI or not? Next. So in the end, a few more rare anomalies. Next. So those vacant optic disc I've shown you in the beginning, and this patient has quite good visual acuity, but he was not all clinic because he had glaucoma, and it's very difficult to follow up because you're not able to measure the retinal nerve fiber layer and the optic disc appearance because the optic disc is just so different. And next. And it's associated with the papillorenal syndrome. So you have a bilateral optic disc anomaly, so vacant optic disc, together with hypoplastic kidneys caused by PAX2 mutation. Next. Morning glory-like anomaly are shown here, and you can, if you look very closely, you see a normal optic disc, but the peripapillary structures are very different, very anomalous. The child has a high myopia, -13 diopter, and has high amblyopia. Next, and those anomalies can be associated with abnormal intracerebral vessels with phase syndrome. So once you see one of these, check for phase. Next. Other excavated optic disc anomalies are the optic disc coloboma, can be associated with chorioretinal coloboma. It's a child with a charge syndrome, and I'm always amazed that you can have a very different optic nerve and you have 20/20 vision. And once you have your optic disc coloboma, can be associated with microphthalmia, orbital disc. Visual development is very variable. Next, but check the brain, the heart, the kidney. Next. So I'm going back to my first slide, and it's showing you all the images next. So I would, or we would recommend a checkup in the images shown here, where it's optic nerve hypoplasia and especially excavated optic nerve anomalies, and they require further checkup. Thank you.
Thank you, Christina. This was an excellent talk. Thank you. I really would like to encourage you again to ask questions into chat. And I would like to introduce our next speaker. This is Sanil Shah, coming from Oxford University Eye Hospital. The title of his talk, The Role of OCT in Pediatric Optic Discs Evaluation. Welcome, Sanil.
Hello, everyone. Good afternoon. My name is Sanil Shah. I'm one of the pediatric ophthalmologists in Oxford. Thanks, Manca, for a very kind introduction. And I would also like to thank ERN for giving me this opportunity to talk here. I'll be talking on OCT in pediatric neuro-ophthalmology. Now, we all know about the principle and advantages of OCT. I will focus mainly on the challenges of OCT in pediatric ophthalmology and various indications. So we know how OCT works and what kind of image it gives. And we also know the advantages that the OCT has revolutionized the adult ophthalmology work. However, there are some challenges with the OCT when it comes to the young children. And that has limited the use of OCT, particularly in children less than 5 years of age, 7 years of age, and also with the children who has other problems like developmental delay, autism, and therefore our use of OCT in young children is limited. However, there are many advantages. So let's start with the challenges. So the first challenge with the OCT in children is the image quality is not very good because of the blink motion artifact, and therefore the quality of the image that we get is not as high with high resolution as we get with the adults. However, still they are useful. So we have been trying to use various kind of machines for OCT in children. So we have tried like flying baby kind of method where we hold the infant in front of the tabletop OCT, but we were struggling and it's not very practical. So then some of our colleagues in nearby NHS hospital has tried the handheld OCT, where the handheld probe is connected with fiber optic with the main console. And we have been using this microscope kind of flex OCT, which is a kind of research device from Heidelberg, which is mounted like a microscope, and we have been using it in our department for OCT in young children where the adult tabletop OCT machine is not useful. Now, the other challenge with the OCT in children has been the change in the optic nerve head with the age, which has been highlighted very well by this paper, where we can see the RNFL thickness keeps on increasing normally in normal children up to the age of 4-5, and then it starts to drop gradually. So therefore, the adult RNFL values are not directly applicable to the pediatric OCTs. And the other query is, if we are using the tabletop OCT, which is designed for adults, can we use the same software and normative database? We have been using it because it saves time. You don't have to, like, the software does the segmentation work and it calculates various parameters automatically. So whenever possible, we use the same tabletop OCT for adults. However, we must be aware that children's optic nerve head parameter are a bit different than adult parameters. So whenever I order OCT for a child, I usually order OCT of RNFL and disc volume with enhanced depth imaging and macula. And I would be looking at RNFL thickness. I would be looking at the cross sections of the section of the optic nerve head, and also the elevation map of the neuroretinal rim. And I would be looking at the macula OCT to look at the ganglion cell layer thickness. Now, this is regarding the tabletop OCT, but the problem with the flex and the handheld OCT they are research instruments, and therefore they don't have sophisticated software. The manufacturing companies have not invested much in developing the normative database for them. So we usually use these parameters published in this article, which are mainly useful for pediatric glaucoma. For optic disc edema query, we use these parameters. So we mainly use cup depth, rim height, and the Brooks membrane angulation to monitor very young children where the tabletop OCT is not possible. And we are monitoring for papilledema query. Now, if we go to the common indications for OCT in pediatric neuro-ophthalmology, there are mainly, like, these are the main indications. I would say optic disc edema query is the most common indication where the OCT is required. Other indications are various optic neuropathies and congenital optic disc anomalies, and they are also useful for pediatric glaucoma and the other CNVM nevus, the secondary complications of various congenital optic disc anomalies. So if you look at the optic disc edema query, the query regarding the diagnosis, like differentiating between true disc edema and pseudo disc edema, mainly comes when the appearance of the optic disc is like Friesen grade 0, 1 or 2. In Friesen grade 3, 4 and 5, it is usually obvious that this is true disc edema and not pseudo disc edema, just looking at the fundus. And as we can see in this paper was for adults. However, it highlights very well that the overdiagnosis or diagnostic errors are very easy to make when we try to differentiate papilledema from pseudopapilledema, and one of the most common error is the ophthalmic assessment of these patients. we can see in this paper that they compared various, like they have looked at various articles and tried to see how accurate various parameters are in differentiating true and pseudo disc edema, and we can see none of them has very high accuracy. However, combining various parameters can be more accurate than using one single parameter alone. So we always use multiple parameters when we try to come to the diagnosis and to monitor the progress. So now let's look at some of the patients which I have encountered in the last 6-7 months. So the first patient, so this was a 9-year-old girl who had occasional headache and vomiting, and visited the outside community optometrist for headache and vomiting, who saw this appearance of the optic disc and referred to the eye casualty. Looking at the optic disc, like the appearance of the disc is like Friesen grade 1. It's not possible to confirm whether it's true disc edema or pseudo disc edema. Also, there is some anomalous branching of the blood vessels on the disc, which might say that it might be pseudo disc edema. However, when we look at the peripapillary RNFL thickness, it is significantly high. And if we look at the cross section of the optic nerve, the Brooks membrane angulation is forward, and the neuroretinal rim is significantly elevated. So looking at the OCT, we can say that this is highly likely that this child is likely to have papilledema. Now, one point I would like to highlight is that, like, it is so easy to make a mistake in confirming or refuting the diagnosis of papilledema that I usually prefer not to confirm or refute the diagnosis of papilledema, and I would rather say the level of suspicion. So I would usually communicate my findings with the pediatrician by saying that this is the suspicion of papilledema is mild, moderate, or very high, rather than confirming or refuting the diagnosis of papilledema. Now, if you look at this other patient, this was a 15-year-old boy who was referred by neurosurgeon because of the headache, and he had ruptured intracranial AV malformation, and they wanted us to rule out papilledema. And we can see the fundoscopy shows right side racemose angioma, and in presence of AV malformation that would be indicative of Weber-Mason syndrome. And the OCT of the right eye shows clearly that the child has swelling of the disc. The left eye is not very suggestive of any swelling, and also the cross section of the disc, the right eye, there is subretinal and intraretinal fluid with significant elevation of neuroretinal rim, as confirming or suggestive of optic disc edema, and the left eye seems to have normal optic disc. Now, if we look at the third patient, this was a 15-year-old girl who presented because of the pain behind her left eye, and the optician had referred with the query of papilledema. This was the appearance of her optic disc, and this was her RNFL thickness map. For the right eye, the RNFL is mildly thicker than normal, and in the left eye, it is significantly thicker than normal. And if we look at the cross section, the right eye maybe a little bit elevated NRR, however, no forward angulation of the Brooks membrane, and the left eye, there is subretinal fluid along with significant elevation of the neuroretinal rim, suggestive of true disc edema on the left side. Right side, we can't be sure. However, one thing to note here is in both eyes, there isn't any forward angulation of the Brooks membrane, and the Brooks membrane are significantly deflected backwards. So therefore, we decided to do ultrasound on this child, and the ultrasound showed there was significant thickening of choroid with P sign on the left side, and she also had reddish saturation, and she turned out to be positive for ANA. So the diagnosis was the left side posterior scleritis and possibly right side pseudo papilledema, pseudo disc edema. and she was treated with oral steroid, and this is how her RNFL thickness changed. So the left eye RNFL thickness improved significantly. Right side change, like less than 10 micron of the change. Many times it can be just test retest variability. So I don't think the right eye change that we see here is significant. Now, moving on to the next patient. So this was a 13-year-old boy who was referred for MRI under GA by my colleagues, just a second opinion, because the boy had autism and needed the MRI under general anesthesia. Before putting the child for the anesthesia for MRI, my colleague asked me to see the child one more time. Looking at the RNFL thickness, we can see the right eye RNFL thickness is high and the left eye RNFL thickness is normal. However, if we look closely and if we look at this the segmentation line, we can see the segmentation line is not very accurate. Therefore, I decided to change the segmentation line and put it appropriately, and we can see the RNFL thickness is normal, and the previous scan showed RNFL thickness to be high is just because erroneous segmentation by the software. So, and also the child had the high reflective margins with hyporeflective echos on the cross section suggestive of optic disc drusen, and the ultrasound also showed drusen in both the eyes. So the message is it is important to look at the segmentation line as well, because many times the machine can make segmentation error, and that can make our decisions incorrect. So next patient is a 13-year-old girl who presented with the typical symptoms of raised intracranial pressure. This was her optic disc appearance, and her MRI was normal, and her RNFL thickness and the cross section of the optic disc was not confirmatory of papilledema, but at the same time it was not normal. So because in view of the symptoms of papilledema, we requested lumbar puncture. However, the lumbar puncture opening pressure was 23. Therefore, the pediatric neurologist suggested that it's likely to be a pseudo disc edema. But to our surprise, when the girl came back in July 22, her optic disc RNFL thickness had worsened significantly, and also the cross section we can see there is forward deflection of the Brooks membrane, and the NRR elevation is higher. So we decided to give her a trial of acetazolamide, which improved the RNFL thickness significantly, along with the elevation of the neuroretinal ring. So the message is that many times the lumbar puncture is not very accurate. The cutoff of 28 for children for opening pressure is arbitrary and may not be accurate. There are many factors with the lumbar puncture which can affect the reliability of the pressure measurement, particularly in the young children when they have to do lumbar puncture under general anesthesia. The anesthesia itself can affect the CSF pressure. So the most reliable way to confirm or refute the diagnosis of papilledema is fundoscopy. And serial monitoring of optic disc with OCT is very helpful, very helpful in confirming or refuting the diagnosis of papilledema. And the acetazolamide trial is also very helpful. Now we looked at the older children. Now let's look at the young children. So this was a 4-month-old boy with the sagittal craniosynostosis who was seen as a part of routine monitoring in craniofacial MDT clinic at our department. In our department, whenever a child with craniosynostosis comes, that child usually is seen by the, apart from the maxillocraniofacial surgeon, they also see the ophthalmologist and get the fundoscopy and the OCT at every visit. So in this child, the OCT did show significant elevation of the neuroretinal rim on both the sides, and fundoscopy was not convincing. There were no hemorrhages on the fundoscopy. However, there were the disc margins were fuzzy, and the child had CT scan which showed signs of raised ICP, and the ICP monitoring showed the high intracranial pressure. Now this 7-year-old, this 3-year-old male with the right unilambdoid synostosis was seen after the fronto-orbital anterior remodeling in 2018. This photograph was taken in 2019 of the left eye. Then the same child had another photograph in 2020 where you can see that the NRR is a bit higher than normal. However, as we know, with the development, the retinal nerve fiber layer thickness increases to some extent. Therefore, we decided to observe. However, when the child came 1 month after, the NRR thickness increased further significantly. Therefore, the child was diagnosed to have papilledema, and the underwent lateral calvarial expansion in October 20, and which improved the neuroretinal rim elevation significantly. So serial monitoring helps also in with the flex OCT in very young children. So we have done some study in these patients with flex OCT in very young children, and in this study, which we would be trying to publish after we have analyzed and gathered more patients, and we have found that the optic cup depth, nasal rim height, and the temporal rim height are the most helpful parameters to monitor these children for papilledema. And the another study where we did the OCT while they were under anesthesia for ICP monitoring, and as their ICP was brought down, we tried to see which parameter on the OCT changes, and we could see that the Brooks membrane deflection or angulation and the cup depth were the most useful parameters, which change very fast with the normalization of the ICP. Now, apart from optic disc edema query, OCT is also very helpful in optic neuropathies. They help in detecting and monitoring any permanent optic nerve damage. Also, there are a couple of articles which have suggested that the OCT changes correlate better with declining vision than the change in the tumor size on MRI. In these studies were done in patients with optic pathway gliomas, and there is a query, or this needs more research, whether the optic disc changes can be used as a trigger for treatment for these optic nerve, optic pathway tumors. So let's look at the patient this was a 9-year-old girl who presented with bilateral vision loss post-viral and had the optic disc edema, and treated with systemic steroids. The girl's RNFL thickness improved significantly over 2 months period between July 22 and the September 22. Her ganglion cell layer thickness was quite normal when she was seen at the first visit. However, her ganglion cell layer thickness declined significantly over the course of 2 months, suggestive of permanent damage to the ganglion cell and the optic nerve, which correlated with the subnormal vision and the visual field defect, which persisted even after resolution of optic disc edema. Now, this 17-year-old male who was being followed up for left eye optic nerve glioma, and he is known to have neurofibromatosis 1, and vision has been stable for the last 2 years, but there has been significant deterioration in visual field. But when the MRI was done, MRI did not show any significant change in the glioma when it was compared. The recent MRI was compared with the 2020 MRI, and there wasn't any significant change. However, if we look at the OCT RNFL and ganglion cell layer thickness, we can see the RNFL thickness has deteriorated significantly. Also, the ganglion cell layer has thinned out. So this suggests that the OCT changes can predate the neuroimaging changes, and we have feedback, like we have sent the feedback to the neurosurgeon, and they are going to discuss it in the MDT to see if they would like to treat this child. Now, OCT is also useful in optic disc anomalies. It helps in diagnosis when the photography is not very helpful or not possible, particularly in the very young children where they can't sit in front of the fundus camera. And also the fundoscopy is many times tricky because you have to use indirect ophthalmoscopy with 20D or 28D, and you can't really see the whole fundus, and the view is so unstable that you might sometimes just get a glimpse of the structures, where the OCT, particularly the flex and the handheld OCT, can take still images and can help in the diagnosis. Also, the temporal RNFL thickness on OCT can help predict the visual prognosis, and they help in monitoring for the secondary complications like CNVM or serous detachment, like in optic disc. Now, so this is one child who presented at the age of 7 months with abnormal eye movement. At that point, the fundoscopy was not very reliable. Like it was noted that the optic disc, glimpse of optic disc with some like pallor, but could not comment on the size of the optic disc. Because of the nystagmus and the subnormal vision, the MRI was ordered, which was normal, and the genetic testing showed PEC6 mutation. However, when the child came at 2 years of age, we could do the OCT, and we could see that the optic disc size was significantly lower, with the Brooks membrane opening size being small, and also the disc macula distance to be on the higher side, and the temporal neuroretinal rim or retinal nerve fiber layer on the temporal side of the disc was not very thick. It was a bit thinner than normal, and which we felt that like might suggest that the visual outcome in the long term might not be very great. And at 5 years of age, we could do the optos images, which confirmed the diagnosis of like that also correlated with the diagnosis of optic disc hypoplasia, and the visual acuity has remained subnormal. So the flex OCT does help in diagnosis because it's easier to take images with the flex OCT as compared to the fundus camera and the optos. However, there are fundus camera which are handheld and can be helpful. However, the OCT also gives us idea about the retinal nerve fiber layer thickness and can help in the prognostication. So the take-home message is OCT in children is difficult to perform but quite rewarding. We must be aware about the changes that happen in the optic nerve head with development. We use adult machine when possible because the software and the database is quite helpful. It saves a lot of time as compared to manual segmentation and use of calipers. The flex OCT and handheld OCT are extremely helpful when everything else is so difficult for diagnosis as well as for serial monitoring with right parameters. And use of multiple parameters to reach conclusion is helpful to confirm or refute disc edema, and also to detect improvement or worsening. And I would say serial monitoring is extremely helpful with serial OCT, particularly with the papilledema queries. Thank you.
Thank you very much, Sanil, for this excellent talk. And now I would like to invite our next speaker. This is my coworker and colleague, Maja Šuštar Habjan, who is the head of Visual Electrodiagnostic Laboratory here at Ljubljana University Eye Hospital. She will talk about the role of visual electrodiagnostic testing in pediatric neuro-ophthalmic cases.
Ladies and gentlemen, my name is Maja Šuštar Habjan. I'm an electrophysiologist in Eye Hospital Ljubljana, and I would like to present some cases that explain the role of visual electrophysiology in pediatric neuro-ophthalmology. I will not lose too many words with methodology, but the basic principle of visual electrophysiology is that a specific light stimuli can cause changes in the electrical potential of either retina or the visual cortex, which can be detected by appropriately placed recording electrodes. In older, well-cooperative children, we use the test standardized by the International Society for Clinical Electrophysiology of Vision. These are EEG for evaluation of RPE function, full-field EEG for peripheral retina, multifocal and pattern EEG for macular function, and the later also for ganglion cell function, and visual evoked potentials for the optic nerves and optic pathways. With infants and less cooperative children, we use a protocol which was developed in Great Ormond Street Hospital in London, also called GORF protocol. It includes flash EEG recorded with skin electrodes and VEP to flash reversal and onset stimulation, of course monocularly whenever possible. Such protocol is possible even with newborns, but it's less precise as standardized methodology and dependent on child's cooperation. Here is our first case, a blind child. According to clinical findings, it was not totally clear whether this is a retinal or optic nerve dysfunction. However, according to electrophysiology, the level of dysfunction is clear. We have no flash EEG in this child, which indicates a severe generalized retinal dysfunction resulting in poor vision. These findings are in keeping with Leber congenital amaurosis. Nystagmus is another common reason for referral to distinguish between idiopathic or sensory causes. Here we have an infant with nystagmus and photophobia, and what we can see in this child is a normal response to rod-specific stimulation with blue light, while absent response to cone-specific stimulation. These findings are in keeping with achromatopsia, which was later also genetically confirmed. Another case of nystagmus, but this time associated with problems with night vision. According to EEG, there is normal photoreceptor function and complete dysfunction of rod bipolar cells, while cone bipolar cells are only partially affected. These findings can be seen already with infants recorded by skin electrodes and indicates characteristic changes for a complete type of CSMB. On the other hand, nystagmus can be associated also with postretinal abnormality, as for example in cases with ocular albinism. In these children, we can see markedly higher flash and onset VEP over the contralateral hemisphere, which indicates excessive crossing of the optic nerve fibers in the chiasm as one of the common findings in ocular albinism. Common reason for referral are also retinal dystrophies. Here we have a case of a little girl with family history of Usher syndrome, which has no problems with vision and has normal findings on ophthalmological examination. However, flash EEG revealed abnormal responses of the peripheral retina as an earlier sign of retinal dystrophy associated with Usher syndrome. Another case of retinal dystrophy is this girl with Stargardt disease. In Stargardt, EEG can distinguish between 3 distinct phenotypes, in which type 3 indicates the most severe disease. According to EEG findings in this girl, macula, as well as the peripheral retinal function, were affected, indicating that this girl unfortunately has type 3, therefore a severe vision loss is expected. This is a case of a boy in which EEG showed a very characteristic pattern of changes, and such pattern is pathognomonic for KCNV2 associated retinopathy. So in rare cases, EEG can also predict a results of genetic testing. Another common reason for referral are optic nerve abnormalities. This is a child with right optic nerve hypoplasia, and the question was whether a visual function is preserved in this eye because the boy did not participate in visual acuity testing. And as you can see, the EEG was normal, while there was no VEP response to flash or pattern stimulation, which indicated that the boy cannot even see the light with his right eye. This is a boy with severe visual loss and bilateral papilla edema. Clinical findings were suspicious of Leber hereditary optic neuropathy. In agreement with this diagnosis, we have seen abnormal N95 wave of the pattern EEG as a sign of ganglion cell dysfunction early in the course of disease, as well as there was marked VEP abnormality. Early involvement of retinal ganglion cells is characteristic of LON, while in other types of optic neuropathies, ganglion cells usually degenerate later in the course of disease. This is a case of a boy which had several episodes of optic neuritis, and with the latest episode there was no improvement of visual acuity. Why? Because there was a retrograde degeneration of retinal ganglion cells, which can be seen from an abnormal N95 wave of the pattern EEG, as well as marked VEP abnormality seen as a delay and decrease of the amplitude. In such manner, electrophysiological evaluation of children with optic neuritis is important, especially if there is no improvement of visual acuity. Let's move to optic pathway abnormalities. Here we have an infant with genetically confirmed neurofibromatosis type 1. Because clinical findings were normal, there was a concern if MRI under general anesthesia is truly necessary. So the question was if visual pathway was truly intact. However, according to VP, it is not, because we have measured mark abnormality. Consequently, the child was sent on MRI, which showed lesions in optic tract and thalamus. Another case of neurofibromatosis and gliomas of both optic nerves, which was yearly followed in our hospital. At the last VEP examination, we have noticed that the fibers that are crossing in the chiasm are more affected as in previous years. Accordingly, he was sent on MRI, which revealed enlargement of glioma towards the chiasm. Interestingly, visual field testing was less sensitive and did not show any temporal visual field effect. And here is my last case because I'm running out of time. This is a young girl in which a question of hemianopsia appeared after the operation of astrocytoma. The problem was that she did not participate in visual field testing because she was only 3 years old. However, VP revealed abnormal response over the right hemisphere, consisted with left-sided homonymous hemianopsia. This was confirmed with visual field testing 3 years later when she managed to participate. So to conclude, what is the role of visual electrophysiology in pediatric neuro-ophthalmology? It enables an objective and non-invasive assessment of visual function in infants and children. By the complementary use of various electrophysiological tests, it enables accurate characterization and localization of this function. It allows distinguishing between disorders that can appear with similar signs and symptoms, as well as between progressive and stationary disorders. However, EEG and VEP findings always need to be interpreted in broader context of other clinical findings. Therefore, close collaboration with pediatric ophthalmologists is really crucial. I'm really happy that I have such a great cooperation with Dr. Manca Tekavčič Pompe. Thank you for your attention.
Thank you very much, Maja. This was really kind. Thank you. I hope Maja raised your interest into pediatric visual electrophysiology, which is really a very great tool to have available in everyday clinical practice. So our last speaker is Susana Noval Martín from Hospital Universitario La Paz in Madrid. The title of her talk is Pediatric Optic Neuritis Protocol. Welcome, Susana.
Thank you. So my name is Susana Noval, and the chief of the Pediatric Ophthalmology Department at La Paz Hospital in Madrid, Spain. And I'm really delighted to have been invited to participate today. So let's talk about optic neuritis in children. Optic neuritis has been classically diagnosed with clinical criteria. You usually have a young or middle-aged woman that presents a unilateral CP-acute visual loss or any kind of visual field defect, usually preceded by orbital pain that worsen on eye movements. And that's the same profile teenagers usually have. And they also have a high association with multiple sclerosis, making the brain MRI the key test. However, optic neuritis in children differs in many cases. Only 1 out of 4 complain of orbital pain. The decrease in visual acuity is usually severe, below 0.1. Bilateral cases can happen at the same time, and at up to 65% of cases, an optic nerve edema has been described. Therefore, what else? We have to take into account that the incidence of optic neuritis in children is at least 10 times lower than in adults. And taking into account that in many of those series, there are a lot of teenagers included in the pediatric population. So, optic neuritis are rare in a pediatric neuro-ophthalmology practice if you compare them to intracranial hypertension or brain tumor, for example. Therefore, if a child attends complaining of bilateral blurred vision and you find a bilateral optic disc edema, you will always first rule out a brain tumor, asking for a cranial CT. And you have to ensure that the blood pressure is not elevated. Recently, an article has been published on diagnosis and classification of optic neuritis in Lancet. Looking at the clinical criteria, we find that many of our pediatric cases cannot be diagnosed just clinically, and that could confirm the diagnosis would need at least 1 or 2 tests, OCT, MRI, or biomarkers. In this article, the first step, the first aim, has to be to distinguish those cases at high risk of relapsing, because those are the ones that will need further treatment. One of the typical monophasic optic neuritis is quite typical in children. And those are those with an infectious origin. They can be due to direct involvement of the optic nerve, and in those cases, the optic disc edema is usually associated with other signs of retinitis, or they can be triggered by almost any kind of infection, even COVID, and some vaccines. So, since they are so frequent, sometimes in the pediatric population, we always have to request serologies for Bartonella hanseníae, Toxoplasma, Mycoplasma pneumoniae, amongst many others. And I have pointed out these three because they are the main, the most common one in my community. So serologies will be our first element in the diagnosis protocol of optic neuritis. However, optic neuritis can be associated to different types of demyelinating diseases. And we all know that the cranial MRI can be really useful, but not always. We always have to try to study also the orbital optic nerve, because there sometimes we have some typical features. For example, a perineuritis or orbital inflammation is typical of MOG antibody disease. And in the neuritis optica, what has been described as typical is to have a long portion of the optic nerve affected, usually the posterior one, and even the chiasm. And since, as we have some, we need this additional test to be able to confirm many of our pediatric cases. We need both things to have additional data. What about the spinal MRI? The decrease in visual acuity in optic neuritis in children is always severe, or not always, but it's quite common. So we cannot use the severity of the visual loss to rule out neuritis optica. And we will ask always for anti-cooperative 4 antibodies in children with optic neuritis. But we will order a spinal MRI only when they have difficulties walking. Because in neuritis optica in children, they usually debut with optic neuritis, and myelitis transfers usually happen in recurrences. So we have three main types of demyelinating diseases: multiple sclerosis, AD, and neuritis optica. The McDonald criteria aren't so precise to diagnose multiple sclerosis in children under 12-year-old, especially if they have encephalopathy that we usually link to AD. The rate of patients that converts to multiple sclerosis may change between studies, and that depends sometimes on the mean age of the population. Here we have a German study, a European one, and the rate of conversion was 42%. But the mean age was 12, so there were a lot of teenagers included. Again, is a multifocal demyelinating disease that is usually typical of children under 10-year-old. And neuritis optica, the incidence is low, and the pediatric cases account for only 4–7% of cases. When there is brainstem involvement, ataxia, or encephalopathy, to distinguish between multiple sclerosis and AD can be really challenging at presentation. Transverse myelitis can also happen in any of these diseases. So sometimes the final diagnosis cannot be obtained until we have a few years of follow-up. So our second key element in our diagnosis protocol is the MRI. But what else? We are missing something. Here we have a 4-year-old girl. She came to the emergency department with headache, not so severe, but with acute bilateral visual loss. That was what their parents said. Then visual acuity was slight perception in both eyes. Her pupils reacted weakly, and we found a moderate papilledema, edema in both eyes with vascular tortuosity. As we said at the beginning, in these cases, we always have to ask for a CT, brain CT, to rule out a brain tumor, for example. It was normal, and she was admitted at the hospital. A lumbar puncture was performed, and she showed a slightly high intracranial hypertension. In the MRI, she has some unspecific demyelinating diseases, but she has one hypertense in T2 lesion at the level of the tampon. So, what was it? Here we have the typical case of a young child with MOG antibodies disease, with some behavior changes, with headache, and severe optic edema associated to visual loss. The proportion of patients with pediatric patients that are positive for anti-MOG in demyelinating diseases may range between 30 and 50%, but including some of them that who otherwise fit criteria of neuritis optica or AD, but not those that convert to multiple sclerosis. So dye makers are really useful to know which of these diseases is going to be monophasic or relapsing. And we have to include here the oligonuclear advance that is associated, that increases the accuracy of the McDonald criteria in children with multiple sclerosis and recurrent optic neuritis attacks. Recently, we have added another test to our protocol in children, because if we review the literature on level of neuropathy in children, we see that the initial presentation is similar. We have an acute or severe acute visual loss that is severe and is painless. But what makes the diagnosis more challenging is that in children, level of optic neuropathy can recover vision spontaneously at the level that 80% of us can recover a visual acuity above 0.5. So we do not want now to know how many of our optic neuritis might be a level of optic neuropathy, and we are checking the three main mutations. This is the third of our key elements in the protocol of optic neuritis. The treatment protocol is similar. The only thing that we have to keep in mind is that we should always taper the oral corticosteroids slowly over 4 to 6 weeks to avoid recurrences with withdrawal. If it happens, you have to start again, to do it slowly, and in many cases, that's enough. As we said, we need to know in which context we are. We can have a monophasic neuritis optica, we can have a monophasic infection of neuritis, or we can have an AD that is monophasic, and they won't need any other treatment. But if we have a factor of risk of recurrency, in case of multiple sclerosis, they will need disease-modifying treatments, and in autoimmune diseases, they need immunosuppressive therapy. So this is our first aim, to be able to identify those patients at risk of recurrency. But I'm a pediatric ophthalmologist, so we have something else. Here we have a 5-year-old girl. She was interning at the intensive care unit with encephalitis, myelitis, and optic neuritis. A few days later, she came to the office. Her visual acuity in the right eye was 0.6, 0.4 in the left eye. But she had an astigmatism in the best visual acuity eye. And the answer was in the OCT, because we already could see that there was a thinning of the ganglion cell layer of the left eye. So that was the eye that was suffering the highest of atrophy. So we prescribed the glasses, we patched her right eye, and in 3 months, the visual acuity in both eyes was equal 0.8, despite that we could see a difference in the retinal nerve fiber layer thickness between right and the left eye. So in children that are below younger than 7 years old, In addition to sensory causes, there is always an amblyoptic component. So we always have to try to patch for at least 3 months, even if we see a severe atrophy. Thank you.
Thank you, everybody, for your excellent talks.